right. Well, hi, everyone. Thank you so much for joining us this evening for our presentation, Beyond the Scope, Why Standards Matter in Fees. This is a TIMS users group session, so a little bit different than our typical CE offerings. We will be talking a bit more about TIMS MVP in tonight's presentation. Here are our learning outcomes and our agenda for the evening. And a couple of housekeeping items to kick things off while everyone's still getting logged on. This course is eligible for 0.15 ASHA CEUs or 1.5 PDHs. If you would like ASHA CEUs for this event, we ask that you stay for the entire duration of the presentation and complete a brief survey within 7 days of this course offering. When Ashley is presenting, I will go ahead and put that survey link in the chat. So if you're on a desktop, you can go ahead and copy and paste it. But if you're on a smartphone and you're not able to paste it, don't worry, we will send it out via Zoom email reminders. And if you don't get those and you don't have access to the survey link, just send us an email at tims-univ@tims.com and we can get that over to you. Additionally, if you'd like a certificate of completion, send us an email at the same email address, tims-univ@tims.com, and we will get that over to you as well. So with that, we will go ahead and talk a bit about our goals for this presentation. So Ashley and I have been working on this for a couple of months, and in putting together this content, we really wanted to help prepare anyone participating this evening for creating a fees program or looking at maintenance and performance as well as fees program development. In creating this content and the objectives for tonight, our hope is that we will prepare you for challenges that you may experience, questions that you may come across, whether you're preparing to begin a fees program, looking at training and competency, or just reevaluating where your fees program is at in its current state. Our motto is knowledge is power, and as speech pathologists ourselves, we want you to know that we are in this with you and we are here to help support you no matter what step in the process you're in. So with that, we will jump into introductions. My name is Brooke McGivern. I am a speech language pathologist and the Director of Marketing and Communications here at TIMS Medical. My disclosures are that I receive a salary from TIMS Medical, Maryville University, and Mercy Medical Center. So with that, I'm going to hand it over to Ashley.
Hi, everyone. Thanks for joining us this evening. My name is Ashley Biliskov. I am one of the managers at TIMS Medical, and my disclosure is that I do receive a salary from TIMS Medical. All right, so let's get started. Fees. I'm sure that many of you know what fees is, and for those that don't, I'm just going to give a really brief overview. As many of you know, fees stands for Flexible Endoscopic Evaluation of the Swallow. Of course, it was developed by Dr. Susan Langmore, and fees is shown to not only be useful for evaluation, but used for treatments worldwide, truthfully, to evaluate swallow. And here's a list of some benefits of fees. This is a very brief overview of some benefits of fees, but the most common ones that we say that we refer to for these benefits are no time restraints. So we are not restrained by the radiology suite, by the next study coming through. So you do have that time to yourself with the patient. No exposure to radiation. In particular, this is very useful for the pediatric or for the NICU population. Use of regular and preferred food, which of course can help promote the participation of the patients in completing the study. You can complete this in a variety of settings, whether it's outpatient, inpatient, SNF, home setting, mobile setting. So this is a great mobile factor. No pauses in recording, the visualization of the larynx, which of course can then lead to early detection if we need to refer to ENT or GI for any purposes, which would also include vocal fold movement, and then beneficial for biofeedback for the patient. Fees or MBS, the great debate. I say both. Of course, it's very particular on which one you'll get some information from. So some studies we get more from MBS, sometimes with patients we get more from the fees. And so if you have the capability and it's appropriate, definitely recommend getting both done for the patient because you can get different answers from both of these studies. Both of these are considered the gold standard for instrumental evaluations for the patient. So if you have the access, use them to your advantage. And so we're going to now talk down the roadmap for developing a fees program for your facility or for your hospital or for your specific setting. So this is a very much an umbrella viewpoint of developing a fees program, and we're going to dive into the majority of these later on in the presentation. So I'm just going to briefly mention these main points on developing a fees program for your facility. First off is determining your team needs, which we will talk about scope and equipment, different reprocessing procedures for your scopes, equipment, and competency trainings for your team. Then we're going to talk about identifying the key advocates in your facility that will help you develop this program and sustain it. Then we're going to talk about writing a proposal, which is a key factor in starting this fees program at your facility. And we're going to talk about all that is encompassing in writing that proposal. As SLPs, we might not necessarily think of the financial part, but that is so important when we are presenting to the executives. We will then talk about meeting with these key decision makers, meeting with your advocates, and the information that you want to be prepared with when you are presenting them with all of this information. Team training, equipment acquisition and setup, because there are multiple different options, a lot of different setups out there that we can talk about, very much dependent on your facility environment. We'll talk about the benefits of fees and that interdisciplinary team and how that comes into play. And then lastly, we'll talk about ROI, so return of investment, and some updates that you want to keep that open communication with the people that helped advocate at the beginning. All right, so fees competency. As many of us know, there is no such thing as a fees certification, but there is a competency and a recommendation on what is considered to be competent. So with what the experts recommend is that you attend a ASHA CE approved course, which typically is held over a weekend. Most of these courses do have an examination completion at the end of those courses. You then have to start with the passes. Now, again, this is all expert recommended, but this can vary. You will have to have your normal scopes around 10 or more. Then your abnormal scopes on your patients. And then lastly, your indirect supervision scopes, which can, again, vary with what your hospital chooses to do. Now, these numbers can change between the adult population and the pediatric population, the NICU population. So do your research on that. In addition, when it comes to these competency numbers, that can depend on your hospital division, your hospital healthcare system. So if a sister facility, for example, already has a fees program in place, they likely, of course, have a protocol and they might have these numbers already established, where then your hospital is going to want to adapt their numbers. So reach out to sister facilities in the area if they have fees program. Also look at your state. Your state might have specific requirements for fees competencies, whether that means being signed off by an ENT versus an SLP. So not only look at your hospital, look at your healthcare system, and then look at your state for their specific requirements when it comes to fees competency.
Awesome. Thanks, Ashley. So now we are going to dive a bit more into equipment. So when you are considering starting a fees program, it's important to be aware of what equipment is needed to start a fees program. And even if you already have a fees program, it's good to kind of reassess your current equipment and equipment that's currently available on the market. So in general, you will need the following items: a camera, processor, light source, microphone, software, and monitor. So those are the basics. Obviously, we need to visualize what we're doing, which requires a video and light source. And then it's crucial that we have that synchronized video and audio, which is why we need microphone access. And software is also a key component when you are looking at fees program development or even assessing where your program is currently at, not only for that recording aspect, but also for study analysis and archiving, which we will dive into later on in this presentation. In addition, you want to check out what monitor you might have access to. In the photo here on the right-hand side, you can see Ashley has a massive monitor, which is not typical. We were at ASHA in that picture, but again, just things to consider. Additionally, you might consider what type of cart you will need. So depending upon the equipment that you select, you may need a larger cart to house all of the equipment. However, like Ashley mentioned, if you are in a different setting, maybe you are, going to different skilled nursing facilities because you're in mobile fees or you have a private practice, you may or may not need a cart. Additionally, of course, we know that we need dye for our trials that we are giving orally, which could be green, blue, or white, or in some cases, you may actually consider using barium based on new research that we will dive into later in this presentation. And then additionally, you may consider using a water-based lubricant, which has the potential to make the exam more comfortable for the patient and potentially make it easier for the endoscopist themselves. Again, we will dive into these topics later in this presentation. Additional considerations are nasal decongestant and topical anesthetics. And then, of course, as Ashley mentioned, one of the benefits of FEES is the fact that we can use patient-preferred food items and liquids. But again, this will be dependent on patient diagnosis as well as other considerations. And then finally, personal protection equipment. So for those of you that are with us this evening that are, skilled endoscopists, I'm sure none of this is new to you, but for those who are starting FEES programs, it's really important to be aware of all of the ins and outs of equipment, tools, and other resources that you will need when you are thinking about starting this program so you can have all of your ducks in a row, if you will, when you go to those advocates that Ashley mentioned. So let's dive into equipment considerations a bit more. The first thing that we think that you should really look at is your site-specific regulations for scope, handling, reprocessing, and storage. This really can drive what equipment you are able to obtain. So as Ashley mentioned, your hospital may have specific requirements for training and competency as well as for scope reprocessing. So for example, many of the hospitals that I have worked at and worked with, and I know the same is true for Ashley, they have used sterilized processing department, which is a specific department within the hospital that reprocesses medical equipment. So I would say that's the thing I see the most commonly occurring. However, some locations may actually allow the speech pathologist or the ENTs to reprocess the scopes themselves, which is a process called high-level disinfectant. So you can see we have a picture here of one of the commonly used products to reprocess scopes, Revitalox. So again, it's just important to be aware, is your facility wanting another department to reprocess the scopes, or are they going to be relying on you to do that? After you've figured that piece out, the next step is to figure out what that looks like. So for example, if SPD is going to be reprocessing your scope, you need to be familiar with how they currently are doing things in terms of the tools, chemicals, etc., because each scope that's on the market has certain specifications for how it needs to be handled and reprocessed. For example, a hospital system that was working with the TIMS teams a few weeks ago was really interested in purchasing a certain scope, but they kind of went down the path of purchasing that equipment and then found out on the back end that their hospital could not obtain or complete reprocessing in the way that that scope required. So they had to go a different route and pivot. So again, just things to consider. Additionally, some healthcare systems decide that they don't want to move forward with the reprocessing, and that is due to concern for cross-contamination, maybe productivity, or concerns for scope damage, which can happen. So maybe then they would opt for a single-use scope. And there are more and more single-use scopes coming onto the market. So I'm sure many are familiar with the Ambu scopes. I know both Karl Storz and Olympus also have new single-use scopes out, and I believe other companies are coming out with their own versions of single-use scope options. So again, there are options for everyone, whether or not you are, wanting to use reusable scopes or single-use. So kind of pivoting back to those reusable scopes, if you do decide to move forward with a scope that you will use time and time again, it's important not only to think about reprocessing, but also to consider the method of transportation of both clean and used scopes. You want to ensure that the scope remains sterile from the time that it is reprocessed until the time you get into the patient's room and you are planning on performing the study. So, considering how am I going to get my scope from point A to point B? And then after the study has been performed, how am I going to get the scope that is then been used on a patient back to the place in which I'm going to be reprocessing it. So in the top right-hand corner here, I've got a photo of a box which the lid can be flipped back and forth between clean or soiled, just indicating, whether or not the scope is clean or if it's not clean. So it's an example. You don't have to use that, but just an example of how you could potentially transport your scope throughout the hospital system. Additionally, a piece that we just mentioned was scope reprocessing, but unfortunately, in our work at TIMS and then in our clinical practice, we've seen time and time again that scopes that are reusable become damaged due to errors in the reprocessing protocol and procedure. So we highly recommend that members of the speech pathology team are aware of the IFU documents. So that's a document that it comes with every scope and tells you the ins and outs of the scope, the specifications, as well as how to reprocess it. It's really important that we are aware of how to reprocess the scope so that we can make sure that, let's say, SPD is in charge of that we're checking in every now and then to see if there has been turnover in the department and if those team members need new training. These scopes are more delicate than a lot of the scopes and they are used to dealing with. So it's absolutely critical that we are ensuring we are all staying up to date on reprocessing the scopes, whether it be speech pathology or SPD. Whoever is doing it really just needs to be aware of reprocessing and handling. Along those lines, it is critical that we are performing a leak test. And we bring this up because, again, we have seen that this is not always consistently occurring. And we want to really drive home the point that this is absolutely critical for patient safety and quality. In the bottom right-hand corner, I have a picture there of a gauge that can be used to assess for leaks in the system. It seriously takes less than a minute to do this test, and it should be performed prior to any use of a flexible endoscope. And this is going to ensure that there is no cross-contamination and that there is no chemicals inside the scope. So not only could that, of course, obviously hinder the quality of the image that you're seeing, but it risks, infecting the patient with cross-contamination or potentially leaking chemicals into the airway. So absolutely critical that that is being performed, which in turn helps with that safety and quality control. And then last but certainly not least is scope storage. So again, every facility is going to be different in terms of what their requirements are. Some facilities and organizations may have an actual dedicated room for endoscope storage, while others may not. So I have an example here of an Aztec EndoCaddy, just an example of, a way in which you could potentially store your scope. But again, it's important to explore this topic with your organization as you are considering what equipment you're going to purchase, because you need to know where that equipment is going to be stored, as well as what the processes are. For example, at a hospital that I was formerly working at, our JCO required that we came in multiple times per month and documented when we came in to clean the EndoCaddy and make sure that the scope was reprocessed in alignment with their recommendations. So again, really important things to consider, not only for study quality, but also patient safety. Plus, I can say this from experience, there is nothing worse than getting all set up, you're all jazzed to do your study in the ICU, and you pull out the equipment and it doesn't work. That is like the worst feeling. So making sure you have these steps in place will reduce the occurrence of that. All right, so let's dive into scope consideration. So as we've already sort of discussed here, there are a lot of scopes on the market, which is amazing. But as Ashley and I say, it's like driving a car. If you drive a Honda Civic versus a Ford F-150, they both get you to your final destination, but they're different. So it's important to consider the different tools and features that the scopes have. So diving into that, I think one of the key things that people often talk about are image quality. So as you will see on the next slide, the scopes that are currently available do vary in terms of their image quality. However, I will say as time goes on and we have more innovations in technology, I continue to see an improvement in image quality, even in the time that I've been a speech language pathologist. So there are a variety of, image qualities on the market, but they're all much better than when I first became a speech pathologist. The second thing to consider, and these are not in any order, but just things to consider. But the next thing on our list is scope diameter. So that's just the size of the scope, which, as Ashley mentioned, if you are considering doing both adult and pediatrics, it's important to be aware of the size of your scope and how that could impact your patient comfort. Toggle function, so that's going to be how you're maneuvering that scope up and down and the way in which you are holding the scope, which we'll dive into in a couple of slides. The light source, so the light source can vary depending upon the equipment itself. So you may have an external light source. So for example, this clinician here in the middle of our screen, she's got a Pentax system hooked up to her TIMS. And with the Olympus system, same thing. You're going to have that external light source and external video source. So, more wires potentially and more equipment. However, typically the image quality of those more traditional stacks are a little bit higher than some of our other scopes like our single use and our USB. That being said, as we're kind of diving into scope types, our USB scopes are extremely mobile. So in this photo in the right-hand side here, you can see the speech pathology team has added the Atmos distal chip, which is a USB scope, to their TIMS. And what you can't really see is inside of this desktop here, there's actually just a laptop. So just like your MacBook you used in college or your Dell computer, it's super light, super mobile, and you can actually just plug your USB scope directly into a USB port on a laptop and take it with you. So if you're in mobile fees or maybe private practice, that's a super awesome tool to have because you don't have to cart around this massive tower. You can easily just take a laptop and go. And similar to this team here, which is Stony Brook, they are in acute care. So this cart itself is extremely mobile and easy to navigate around the ICU because there's less equipment involved. It's just that laptop with the scope, and then the cart has, storage for things that they might be taking with them. And then last but certainly not least are those single-use scopes that I already mentioned, which do help to avoid the potential challenges that occur with scope reprocessing, such as scope damage, which can have cause downtime in your fees program, as well as concerns for quality control and cross-contamination. And so, those might be another option. And don't think that you're locked into, just the USB or traditional or single use. Many healthcare systems across the United States are creating what we call hybrid programs where they have multiple types of equipment. Numerous hospitals we've seen recently are, using either a USB and a traditional scope in conjunction with single-use options in certain units within the hospital. So, that can help increase access to endoscopy, and again, just really help with that patient throughput and access to care. And then another consideration that we think is important when looking at scopes available on the market are whether or not you can access and trial the scope ahead of purchasing. So we think it's really important, just as in using the metaphor of driving a car, to actually try it out ahead of purchasing. So considering the image quality, what is the weight of the scope like? What pieces of equipment do I need? Do I like how this toggle functions? Am I okay with this light source, etc.? So, asking the companies that you are reaching out to whether or not you can access and trial the scope, we think is really beneficial. Of course, most of the companies are going to have examples of image quality and maybe looper videos, but if you can get your hands on the actual scope, we recommend doing so. All right, so let's go through some image samples. So I've got several image samples from a variety of companies here on the screen. So we're going to start on the left-hand side. So you can see here I've got two images from our colleagues at Ambu. So Ambu is a single-use scope option that I'm sure many of you are familiar with if you've taken a fees course or maybe you're using Ambu in your practice. So those are an example from our friends at Ambu. And then below our Ambu images are examples from our coworkers at Atmos. So this is the Atmos distal chip scope, which is USB. So that's the scope, one of the scopes that I mentioned that is extremely portable. You can plug it right into a laptop and go. So awesome option there. And then moving up to our top right-hand corner here, we've got image examples from our colleagues over at Optum. This again is a USB option. It is fiber optic, which is why it looks a little bit different than our other options here on the screen. But again, it is extremely portable. And then below that, we've got examples from two of our more quote unquote traditional endoscopy towers, our Karl Storz here on the right-hand side, and then our Olympus, or excuse me, our Karl Storz on the left-hand side and our Olympus on the right-hand side. And then in the bottom right-hand corner here, we've got an example from our friends over at Patcom Medical. And again, this is a distal chip option that is USB. So plug and play, super easy to transport, and does have that distal chip technology. And also, I don't think I said this at the beginning, but this is being recorded, and these slides are available actually already on our website. So if you miss anything, don't worry, you can go back and check out these images and check out this information. All right, so moving along in terms of other considerations, the scope diameter and the depth of field. So I already touched a bit on scope diameter, but it's the size of the scope. And typically what we see is that scope diameter ranges from about 2 to 3 millimeters on the market. And as Ashley mentioned, if you're thinking about working in pediatrics, it's really important to be aware of the current expert guidelines on which scopes are more preferred for the pediatric population versus adult. However, when you're considering scope size in general, here are a couple of things to think about. The smaller the diameter of the scope, potentially the greater comfort, the reduced risk of trauma, as well as potentially increased ease and maneuverability in small anatomical structures. That being said, typically a larger diameter scope may provide higher image quality, better illumination, and potentially may maintain a better balance of flexibility and sturdiness. So again, just things to think about. And I will say, as I mentioned, we are continuing to see new innovations on the market, some of which are not yet available because they're still going through FDA approval process. However, I think that we are going to continue to see scopes that are smaller and smaller in size with maintained high image quality. So more to come, but the things that are on the market right now are still pretty awesome. All right, so next let's talk about depth of field, which is measured in millimeters. Depth of field is the range of which items will be in focus. So the more depth of field you have, the more area you will have in focus. Basically, this reduces the need to consistently adjust your endoscope positioning when you are performing flexible endoscopy. And you should be able to see all of these specs that we're going through on the manufacturer website or reach out to them and they can give those to you. Additionally, if you want to learn more about equipment, we do have another presentation from last year called Fees Your Way, in which we really deep dive into this stuff. All right, so switching gears, let's talk about field of view and articulation, additional things to consider in terms of your equipment. So the field of view, I've got an infograph here on the left-hand side. This is the angle that's provided, by the lens and the camera technology. So this angle here, and it ranges from 90 degrees plus. And then the other thing to consider is your articulation, which again is represented in degrees, and it's the distance of the scope movement up and down. So in this infograph here on the right-hand side, you can see this scope going through the range of motion. So this angle here may vary based on the scope, how the scope is manufactured. So again, just things to think about, and that's why I really like having the scopes in my hand, so you can actually compare them side by side and like look at that angulation, how big or small it is, and what is the distance of scope movement up and down. Okay, so a little bit more on scope handling and orientation. I briefly talked about toggle function earlier, but I do think, getting your hand on the scope ahead of time is great because then you can actually feel how easy or difficult it is to move the toggle in general. We've had some feedback about a variety of scopes in terms of ease or difficulty level. So again, just things to consider. In addition, when you are handling your scope, it's important that you are aware of, what equipment you're going to be using in your everyday practice and whether or not that equipment is going to allow you to scope in a certain way. So we want to preface that there's no right or wrong way to utilize a scope, but it is important to be aware of how your team will be being trained in terms of flexible endoscopy or how they prefer already to pass the scope. Some scopes can be used in either way and some scopes cannot. So let's kind of talk through that. In the left-hand picture here, you can see that Jonathan is scoping me with an Ambu. That's one of the single-use scopes that we just talked about. So you can see that his thumb is here on the toggle and his other four fingers are on top of the scope, so handling it like this. Typically, we see this referred to as an ENT style of endoscopy, and often SLPs that pass this way typically were trained by ENTs or by speech pathologists were trained by ENTs, versus this photo on the right-hand side. This clinician is using the Atmos distal chip that we mentioned, and you can see that her thumb is again on the toggle, but her other four fingers are on the base of the scope, so like this, which is often referred to as pistol grip style. So, again, just things to be aware of. Some of the scopes you can use in either way, as I mentioned, such as the Ambu scope, the Olympus scope, and some of the other scopes on the market, whereas some scopes can only be used in that pistol grip style, like the Atmos and the PATCOM. So again, just things to be aware of. If you've got people on the team that prefer to scope one way, and then some that prefer to scope the other way. If your equipment can be used in both ways, you can actually adjust the view on the monitor to be in alignment with how you are passing the scope. And it is extremely easy to do that in TIMS. So if you have TIMS and you're wanting to do that, reach out to us. We've got a document that has step-by-step instructions. All right, so a little bit more on toggle function, light source, and scope weight. So we just went through pistol grip or ENT style, and I briefly talked about light source location. So let's dive into that a little bit more. Some of the equipment on the market, as I mentioned, have an external light source that you plug your equipment into. So for example, in my practice, I use an Olympus scope, which does have that external light source. So, I really like the system I have. It has great image quality. But, for some people, maybe they don't want the extra cords coming off that are required with that type of technology where you have the external light and video source. Other scopes on the market, like our distal chip scopes, will have the light source maybe in the handle or in the tip of the scope. And why this is important for us to be aware of, excuse me, is because some patient reports and some participants in FEES training and competency courses have mentioned that intermittently they're experiencing discomfort due to the heat caused by the light source being in the tip of the scope. So I will say in my experience, I have rarely heard that. It's been, few and far between that I have heard that, but again, just something to consider when you are purchasing equipment. And then last but certainly not least is that scope weight that we mentioned earlier. So all of the scopes on the market are different in terms of how much they weigh. So maybe you are someone who wants a lighter scope because you're doing a ton of FEES throughout the day, or maybe your studies are typically longer, or maybe you're someone who likes a little bit more biofeedback, so you prefer a scope that has a little bit more weight to it. Again, with the car analogy, it's just all about what your preference is. All right, so moving right along to software considerations. Often we see that teams really focus on the scope specific information, which is obviously extremely crucial, but sometimes that software piece is kind of forgotten until the purchase has been made. So we really want to hit home the importance of considering your software. So at, just foundational level, the equipment that you purchase with software needs to have the ability to record both synchronized video and audio, just like we have in our NBS world, which, has been commonplace for a long time. We need to have that same ability in FEES to have our video and audio recorded so that we're able to see what's going on as well as hear our dialogue and the patient responses. Additionally, at that foundational level, we need to have the ability to review frame by frame. We see in the literature that, unfortunately, if we are reviewing on the fly, we often are not as accurate as we would like to be. So having the ability to review frame by frame is absolutely crucial with those additional tools of reviewing clips in slow motion or fast forwarding. Additionally, being in 2025 with those new innovations that we've been talking about, we at TIMS think that your software really should elevate your care and help with efficiency, patient throughput, and the implementation of standards, which is why we believe that your FEES software should allow you the use of standardized analysis tools, which will not only help elevate your own, individual FEES analysis, but also will better to help support the implementation of standards across the team. Further tools that you might look for in FEES software are the ability to add in telestrations, which help you point out pertinent information in the study. As Ashley mentioned, we may come across something that, excuse me, that we want to ping ENT about, such as a nodule or polyp-like presentation, etc. So telestrations can be extremely beneficial for that. And we can take snapshots of that information and share it with the team. Excuse me, one second. Okay. And then finally, we really want to be able to pan down our recordings to help reduce the file size and get to that pertinent information in our study. So we can do so with the creation of video clips and ensuring that our software actually compresses the file size. So this is something that we often find that people aren't aware of, that your software should be able to compress the file size down to be in alignment with IT requirements. And Ashley's going to dive into that a little bit later on in this presentation. And then finally, you want to make sure that you're able to actually archive your study over to PACS or VNA. Unfortunately, there are not a lot of software options on the market that allow you to do so. So you want to make sure that you're asking the company whether or not you can actually archive your study with the software and whether or not that information can be integrated into your EMR. All right, so don't just take our word for this. What did the experts say? We did a deep dive into the literature to see what the experts actually recommend. And as I mentioned, at baseline, they do recommend that you have that synchronized video and audio recording with frame-by-frame review. So this information comes from Grower and Crary, Langmore et al., and Miller et al. They recommend that you have that synchronized video and audio, that you're able to review frame by frame, that you can review series in slow motion, that you have the opportunity to provide biofeedback, to review and fast forward, and the opportunity for interdisciplinary team analysis, as we just mentioned with those snapshot features and EMR integration, and that you have HIPAA compliant recording, archiving, and that the patient has the access to the information. And with that, I'm going to hand it over to Ashley as she discusses a little bit more about FEES cards.
All right, so for FEES setup, this of course can vary, and I recommend that you of course choose it based off of your environment. So if you're needing something more mobile, you're starting a mobile FEES company, you're jumping between buildings, you're jumping between hospitals that you need to complete FEES as a sole SLP, which I know many of you are, then there's the ability to have the software and a whole FEES program on a laptop. You plug in a USB scope and you're ready to go. If you're within a hospital or within one building, then you can have the more traditional cart where you have the monitor and then you have your USB scopes. There's another picture here of, I believe that is an Olympus tower with our hardware on it. And then we have another picture here with an Ambu tablet. So we are completely adaptable to any setup, really any setup that is specific to your environment that you need. The goal here is, if it's for you, it's the portability is super important. And is what is your function? So what exactly do you need this to work on? So make sure that whatever you choose, it works for you and it's not making your day-to-day more complicated. Next slide. All right, company support, super important. And I know this is not something that we kind of think of off the bat when we're thinking about starting a FEES program, but please look into this. Please do your research. I promise that later on, you're going to be very grateful that you looked into this information. When you are choosing your software program, when you are choosing your scope, your software, or you're choosing your scope company, please look into what they provide. So, for example, for the scope company, what kind of technical support do they offer? I promise you will need the technical support. I know that you're going to say nothing's going to happen to my scope. Something will happen to your scope. So look into the technical support, see what they offer. Look into their scope loaner program, which I'm going to dive into in the next slide. and then see what kind of training they give you for either sterile processing department, or if your team is planning on doing high-level disinfectant, see what type of training that they offer you. So look into the company support because it will pay off later down the road. If you end up choosing a scope company or a software company that does not offer great support, the likelihood is that your hospital is not going to now just give you a new scope next year because you're not getting a lot of help from this scope company. So do your research early. Now, in terms of the scope loaner program, you want to ask these questions up front. You want to get these answers early before you choose your scope. Advanced replacement. Should something happen to your scope, do they have an advanced replacement program where they will send you a scope right away, so that there is no downtime for your fees programs? In addition, what is that turnaround time? Are you going to be waiting 3 days, 4 days? The longer you wait, the longer these patients have to wait to get fees. Now, in these scope loaner programs, I do want you to also include your sterile processing department, their director, into these conversations. What's happened to me in the past in a hospital that I worked at, the sterile processing department chose, we don't, they did not want to purchase the scope loaner program or have that insurance with the scope company. They decided when our scope broke, they sent it off to a third party. What happened was that when a third party has their hands on a scope, that scope company most of the time will now refuse to work on it because there is a third party piece in there. So now your hospital has to purchase a new scope if that scope now breaks. So then there is a downtime. Now you're waiting for another approval for another scope. So this scope loaner program is really important that you do your research and that your SPD is on board with it as well, and that you ask what that turnaround time is going to be for them to fix your scope. Are you going to get your scope back? Are they sending you a new one if it's not working well? So ask all of these questions up front. This is your kind of umbrella view of what a fees study should look like or could look like. So you, of course, you perform the study, you analyze and you review it, very important. Write your report, upload to your PACS, your VNA, your EMR as your long-term archiving, as we've spoken about the importance of archiving your studies, not just keeping it on your laptop or keeping it on your cart, but giving that patient information, giving the patient access to that information down the road. Okay, some performance considerations for fees. Let's dive into that. Who is in the room? Who is completing these studies? You can have one SLP, you can have two SLPs. A lot of the times we need to consider how much time is it taking us to complete the study? Because initially you're thinking, I'm just going to walk in, do the study, walk out. We know that there's a lot more to that. You're setting up the room with all the trials. You're setting up the patient. Now you're performing the study. You're cleaning up after the study. You're educating the doctor, educating the patient, educating the family, educating the nurse. And so there is a lot of time that can encompass a fees. So there is the ability to have another SLP in there with you. One of you can be administering the trials. One of you can be passing the scope. You can, and that does become a little bit of a dance where you end up learning what each of you do. And the more you do it with another SLP, the quicker you become at that process. And so we do have to consider how much time it's taking, of course, for that productivity concern. And then the scope lubrication. So this does become a little bit more of an SLP preference if you prefer to use lubricant and not. I definitely think that there's benefit to it, especially for those patients that are really dry, maybe after being on BiPAP for a long time or high flow, they do have really dry nasal cavity where lubricant can definitely benefit the patient. So just when you're using it, just be cautious of where you're placing it. You don't want to place it on the tip of the scope. It can kind of gunk up your viewpoint, but it can be useful to an extent.
Awesome. Thanks, Ashley. So now we are going to dive a little bit more into fees performance in terms of the trials that we are administering, as well as the use of dyes and just fees performance in general. And I would recommend that If you haven't already, you should check out the presentation by Lori Winterholm and Aaron Padilla called Finding Our Way with Fees. It was recorded earlier this year, and I know Aaron he dove into some of the research we will discuss this evening in that webinar as well. So looking at this first study, which was completed by Dr. James Curtis and colleagues in 2019, 30 adults underwent fees during which they were administered 5 milliliters of thin liquid boluses, one each randomized. These trials included white water, blue water, white milk, blue milk, and barium water. This study aimed to assess the effects of coating, color, and opacity. Blind video analysis was completed to assess for the presence of pharyngeal residue, penetration, and aspiration. Pharyngeal residue was detected more frequently for liquids that were blue, had a coating effect, or were opaque compared to liquids that were white, did not have a coating effect, or were translucent. Penetration and aspiration were detected more often for those that had a coating effect, but not for trials that were blue or opaque. So that was a lot of information. So what is our clinical takeaway from this study? This study indicates that coating is a critical factor in detecting thin liquid residue, penetration, and aspiration during fees. Based on this evidence, the standardized use of boluses with a coating effect, such as white dyed water or barium, is strongly recommended to improve the sensitivity of identifying swallowing safety and efficiency impairments. So I know, the use of dye has come up pretty frequently in recent posts in the Fees and MBS group on Facebook. So again, just things to be considering. I was actually talking with a colleague over at Bracco last week about this topic and, whether or not anecdotally she's seen more people using thin liquid barium from Bracco in recent years for fees. And she said yes. So just again, based on this study, it might be worth considering how we are or what we are using to dye our trials when we are performing fees. All right, so diving a little bit more into this topic, in a study completed by Marvin et al. In 2016, 40 adult inpatients underwent fees during which trials of nectar thick milk and thin milk with and without green food dye were administered. 3 speech pathologists rated aspiration and penetration, and a subset of the participants that demonstrated secretions was analyzed for the detection of airway invasion. The results of the study demonstrated no significant differences between the dyes in terms of airway invasion with the given bolus types within participants. However, differences were found in penetration for large volumes of thin liquids between participants. Deeper airway invasion was measured for green dyed boluses as compared to white boluses. Repeat rate of reliability was better for green dye compared to natural liquids. So, in summing this up, the clinical takeaway from this study is that findings suggest that the use of dye may improve the identification of airway invasion. All right, let's talk a little bit more about puree types in food coloring. Again, in a study performed by Dr. James Curtis and colleagues in 2025, 37 adults in the outpatient setting underwent fees during which they were provided with 2 puree types, 5 milliliters of applesauce and 5 milliliters of pudding. The purees were presented with green or blue food dye as well as in their natural form. Patients were provided with 1 trial of each of the purees with either the green or the blue food coloring, and then trials in their natural form. The order of the presentation was randomized, and pharyngeal residue, penetration, and aspiration were all assessed. All data were blindly analyzed by pairs of independent raters using VASES. Findings revealed that pudding trials were associated with higher oral pharyngeal residue ratings when compared to applesauce. Applesauce that was dyed blue had a higher oral pharyngeal and hypopharyngeal residue rating compared to natural applesauce. Both applesauce and pudding that were dyed green were associated with higher hypopharyngeal residue ratings compared to the trials in their natural form. So again, a lot of great information. What is the clinical takeaway? The standardization of the type and color of pureed food used during fees should be considered. Both blue and green dye in puree were associated with higher residue ratings compared to natural. Pudding may result in higher oral pharyngeal residue ratings compared to applesauce. So another topic that frequently comes up when considering fees program development and fees performance in general is the use of topical nasal anesthetic. However, many speech pathologists over the years have voiced concerns regarding the use of topical anesthetics due to the potential of desensitization of the pharyngeal and laryngeal mucosa, additionally with the potential of sensory and motor impact. To assess these concerns, Camerunas et al. In 2014 performed a double-blind, randomized controlled crossover clinical trial to assess how gel TNA during FEES with sensory testing impacts sensation, swallowing, and comfort in 36 healthy adult participants. The findings of this study revealed faster bolus dwell time when TNA was used compared to when it was not used. So this means that swallow initiation occurred more quickly when the gel TNA was used compared to when it was not used. No other measures changed. Sensory thresholds and perceptions did not change between participants. No changes were noted regarding subject comfort scores, ease of the exam, or quality of the view. They concluded that future studies should assess TNA variables because obviously there are a variety of TNA products on the market, so they recommended that further research should be conducted. The clinical takeaway from this study was that they found TNA does not impact sensation. However, it may not provide improved patient comfort or ease of the exam. All right, so let's talk a little bit more about patient safety and quality. As we know, endoscopy has a lot of benefits that we discussed at the beginning of this presentation. However, it can pose many risks to both patient safety and quality if appropriate protocols and procedures are not followed. So as we discussed in scope reprocessing, some of these risks can include exposure to chemicals, cross-contamination, as well as challenges on the patient side of understanding information or accessing their own medical records. So things to consider when you are developing your program, or maybe you're, reassessing where your program's at right now. How, thorough are our protocols and processes? Are there areas that we can improve upon? You want to look at your scope handling and reprocessing procedures. Is everyone, that's handling the scope and reprocessing it aware of the instructions for use document that I mentioned? Are they aware of the ins and outs of the scope, what products the scope is approved for use with, et cetera? When you want to check in with your SBD department to see, has there been any turnover? Do new staff members need to be trained? Or, if you're doing high-level disinfectant yourself, is every team member that is handling the scope trained in those processes? Additionally, as we know, it's absolutely crucial that we are getting informed consent from our patients regarding the procedure prior to performing the FEES study. Now, I bring this up because, as Ashley mentioned, with the training and competency, and as we talked about with scope reprocessing, this can actually vary based on your state and your hospital system. So for example, in a hospital I used to work at in Kansas, they actually required that the patient sign a document that was then uploaded into the medical record, and that had to be completed with a witness prior to performing FEES, versus other hospitals I worked at, it's we just need to obtain verbal consent and document that in our report. So it's really important that you are aware of what your state and individual hospital requirements are for informed consent. And then, of course, we want to be providing the patient with the information about the risks and the benefits and how to communicate with us during the study. I always, tell my patients that if they need to discontinue the study or they need to express something during the study, to feel free to do so. And we talk about the best methods of which to do that. Especially as we all know, as speech language pathologists, some of the patients that we are doing FEES with may have cognitive and communication impairments. So it's really critical that we are looking at the whole picture and understanding our patients' cognitive and communication skills and how that might hinder understanding of this procedure and whether or not we need to, get that verbal consent from a medical decision maker. And that kind of pairs into this next bullet point here, which is the patient understanding of our results and recommendations. So again, when we're thinking about software, it's important that we have software that can allow us to record that FEES study and then, if appropriate, play it back to the patient and their caregivers or family and kind of walk through what we are seeing during the study and what our recommendations are. And you can do that right there in the room, depending upon your equipment. And then finally, that last piece of access to information, as Ashley touched on, it's critical that we are able to actually get this information over to PACS or VNA, which if you are not familiar with those terms, I like to think of them as the medical iCloud, if you will. It's, where all of the medical records, including images such as MRI, CT, hopefully fees, and your video fluoroscopy are housed so that the patient and the interdisciplinary team can access them. All right, so more on software. We've talked a lot about the study performance. So let's say we're done with our study and now we are actually in the analysis standpoint. As we saw earlier in this presentation, experts in the field of speech language pathology recommend that you have access to that frame-by-frame review with synchronized video and audio so that you're able to see what was happening, what you were recommending to the patient, and what their feedback was. Additionally, as we mentioned, it's beneficial to have those analysis tools that are going to help you elevate your care and implement standards within the team. And some of these analysis tools may include secretion rating scales, edema rating scales, and tools that assess safety and efficiency. And for more of a deep dive on this topic, I recommend that you go back and watch the presentation, The Art and Science of Fees Analysis by Selena Reese, which is excellent. And she does a deep dive into fees analysis, including rating scales and reporting. Additionally, as I already mentioned earlier in this presentation, annotations and illustrations can be beneficial. If you take a look at this photo here that I've got on the screen, we've just got an example of illustrations and annotations, which can really help just draw the eyes of the interdisciplinary team to what it is that you are describing. At the beginning of my career in doing fees, I was not able to take snapshots and put them into the EMR, so I was totally reliant on my writing skills and describing what I was seeing. And oftentimes I would have physicians, call and say, can you tell me a little bit more about what you were seeing? And of course, if you can't share those images and you can't point things out, it makes delays in care and potentially the need for repeat scope. So illustrations and annotations are beneficial. Just a couple of months ago, I was seeing a patient in the acute care setting, and based on his symptoms, I decided to move forward with the fees. And during the study, I saw what I hypothesized to be potentially malignant disease. So I was able to, take that recording back to my office, add in illustrations and annotations, take a snapshot, and actually upload that via secure chat in Epic to the ENT team, which really expedited the patient's care. But I also am able to include any snapshots into my EMR, which again, help to give picture to what I'm describing in my fees analysis. So again, things to think about. Video editing tools, as I mentioned, you can actually go through your video and remove unnecessary data and create subclips that are smaller in file size. And then you want to make sure that your software can compress the file down in alignment with IT requirements. And then a couple of other tools that we think are really cool that we have in the TIMS MVP software are swallow detection and the compare feature. So our swallow detection is a feature in the TIMS software that actually detects when whiteout occurred. And so if your patient does have whiteout, it will appear as little gray lines on the timeline. So you're able to just easily scrub back to that occurrence of whiteout, and it just helps really speed up the analysis process. And we do want to note that we are aware that whiteout does not mean swallow initiation, but that is just what the software uses to delineate when a swallow may have occurred. And then finally, that compare feature, which you'll see here in a demo in a couple of minutes, which is really beneficial because it allows us to assess between studies or within a study. So if I want to compare two trials side by side, I can easily do so with the compare feature. Or if I'm wanting to maybe compare the patient's fees to their MBS, or maybe their baseline fees to their fees after 8 weeks of treatment, I can easily do so in the compare feature. So as I mentioned, there are a lot of analysis tools. And again, when you are thinking about purchasing fees equipment, you can be asking for some of this information. What analysis tools do you have in your software? So some examples of tools that you may ask about are the New Zealand Secretion Scale, the Yale Pharyngeal Residue Severity Rating Scale, the Revised Patterson, which looks at internal edema, post head and neck cancer treatment, Dynamic Imaging Grade of Swallowing Toxicity for fees, more frequently referred to as digest fees, the Penetration Aspiration Scale, which I'm sure you all are familiar with, the Murray Secretion Scale, and the Visual Analysis of Swallowing Efficiency and Safety, so VASES. And I will say that almost all of these are actually already in the TIMS MVP software. And if you see one that's on the list that's not in the software yet, just know that it is most likely coming. And we will say that this list is not exhaustive, but again, just examples of tools that you may find in software. So, in kind of wrapping up, this section, what components should be included in a FEES report? If you're someone who has performed modified barium swallow studies but are new to FEES, this isn't going to be extremely foreign to you. However, as we know, FEES and MBS differ, and so there are components of the FEES report that are a little bit different than your MBS. So obviously, we want to include the reason for the patient referral. We want to talk about the patient's lived experience. What are they reporting in the interview process? What symptoms are they experiencing? How is it impacting their quality of life, etc.? Your findings from your cranial nerve exam, your oral mech exam, and the results of your clinical swallow evaluation may be beneficial to include as warranted, depending upon your setting. And then, of course, that education, counseling, and informed consent prior to the study is important to include in your FEES report. And then from there, you want to move on to discussing those pre-swallow tasks, which again, Selena discussed those in depth in her presentation, but it's important to document those. And then describing what you're visualizing in terms of the anatomy in that home position prior to any oral trials. From there, we're going to administer our trials and provide information about what trials were provided. And as we just discussed in reviewing some of the literature earlier in this presentation, in our opinion, it's important to not only discuss what trials were administered, but the amount of the trials, as well as the type of dye you used, or if you use barium. So discussing that, and then scoring tools. So we just went through those, providing that objective information with tools such as Digest FEES, the revised Patterson, etc. And then your analysis. So what impairments did you visualize during the study? What were the results of those impairments? Did the impairments result in residue, penetration, aspiration? And if so, what was the patient's response to those events? And was the response effective or ineffective? Additionally, did you recommend any compensatory strategies? If so, what were those? Were they effective or ineffective? And then finally, what are the cause of the impairments? So those are, all things to consider adding into your analysis section. And then, of course, from there, we are going to dive into our recommendations. So what are our clinical recommendations? What are the patient's preferences, their values, and their goals? And then, of course, we want to make sure the patient is at the center of the hub of decision-making, and we want to ensure that we are providing shared decision-making with the patient to develop that plan of care. Based on all of that, we will then move forward with determining our short and long-term goals as appropriate. And then finally, that education and counseling piece. So, really putting the patient at the center of all of this, we truly believe and we see from an ethical standpoint that it's absolutely crucial that patients have autonomy in their decision making. We know that patients do have a right to their health information under HIPAA, but what we've seen in our own clinical practices and in working with thousands of healthcare professionals is that often there is a barrier in accessing endoscopic imagery, not only within the speech-language pathology realm, but within other departments as well. GI and ENT are two departments that come. So with it being 2025 and innovations in, this medical equipment and software, we really encourage you to talk with your healthcare teams about increasing patient autonomy and increasing patients' abilities to access their health information. We see in the literature that access to health records helps patients improve management of complex and chronic diseases, increases the adherence to recommended interventions, and it really puts patients in the driver's seat of their health. So when you're thinking about developing a FEES program, or maybe you already have a FEES program, but you're not super jazzed about the software that you have, thinking about how you can leverage software to really put patients in that driver's seat and help them increase their ability to access their medical records. As we all know, sometimes patients want second opinions. Maybe they move and they want to bring their, health records with them. So it's, again, important to think about. A couple of months ago, we were on a webinar with the NFOSD, and a patient actually logged on to the presentation and was listening, and the patient had chronic dysphagia, and they shared that they were frustrated that they weren't able to easily access their modified barium swallow study and their FEES images. And this is something that we frequently see in our work here with TIMS, that patients, they're getting used to having that access, and it is their right to have access to this imagery. So again, just thinking about how we as clinicians and patient advocates can really work towards helping our patients get the tools they need to make informed decisions. And with that being said, as I already mentioned, the software, when it has EMR integration and the ability to archive to PACS or VNA, it does help with that interdisciplinary collaboration, because then every member of the team can then access the images. There's no barriers to doing so. So it can help improve the efficiency of interventions. It can help reduce unnecessary repeat procedures. And it just really helps improve the quality of care we're able to provide, as well as patient throughput. So with that, I'm going to hand it over to Ashley as she dives into billing for fees.
Okay, so for billing, there is a couple of different options. So there is, of course, the code to bill the whole procedure. There is a separate code for fees that you can use if you are just interpreting and reporting. And then there is also the treatment of dysphagia. There's that code as well that can be used during the fees process. For reimbursement, the rates of reimbursement do vary regarding a variety of aspects. So I do recommend that you log into the website for Centers for Medicare and Medicaid to dive into that. But as Brooke has been mentioning, the archiving piece, reimbursement can be impacted by not archiving fees. And this is super important for SLPs to know. At the beginning of my career, billing was not any sort of topic that I looked into. I would put some codes in and I would go about my day, not really understanding what these codes mean. And I really want to empower the SLPs to dive into the codes that they're charging every day. Your name is on those codes. You are charging the patient. Your license is charging these patients. So when you are using these codes, make sure that you are using them appropriately. So for reimbursement on fees, it can be altered if you are not archiving those fee studies. And when you are not being reimbursed completely, your hospital is getting less money. If your hospital is getting less money, you are maybe not providing the appropriate number when you originally spoke to them about return of investment. So keep all of that in mind when you are choosing your software for your fees program and you are writing this proposal. When you are talking about reimbursement for fees, make sure you have the ability from your software to actually archive to a PACS or a VNA. Okay, so the typical workflow for fees when using TIMS. So you complete your study on your laptop, you complete your study on your tower, wherever you complete your study. And then instead of sending it straight to PACS, because of course TIMS does have the ability to send to PACS, instead of sending it straight to PACS, TIMS has something called a TIMS review workstation. So what that does is it's a license that gets placed on a SLP computer of your choosing. So it could be your laptop, it could be another desktop in the SLP common work area. And this allows you to view your studies outside of that fees cart or outside of that scoping laptop. So the nice thing about having that TIMS review workstation is that you can then pass on that cart to the next SLP to complete their study while you then go back to your computer and review it. Instead of just reviewing it from PACS, the TIMS review workstation allows you to review it with audio, including all of the features that the TIMS unit has. So this is a great workflow. And then from that TIMS review station, you can then send to PACS. So it could be your fees cart straight to PACS or your fees cart, TIMS review, and then to PACS. And of course, that integration with EMR, which I did see someone just ask the question about Epic. Yes, we have the ability to integrate with your EMR, and we can dive into that a little bit later during the questions. Okay, I made this a slide because this is such a barrier for so many SLPs. I do not want your program for fees to get stopped by your PACS administrator or your IT department saying that the file sizes for fees are too large and you cannot archive. There is a workaround. And this is not a thought that you have at the beginning of when you're starting your fees program. So this will come up. This absolutely will come up with your PACS administrator and your IT department. When you are going to when you say that you're going to archive your fee study and you tell them that it's a 10-15 minute study, their eyes are going to pop out of their head because that is a very large study to archive. However, what the TIMS software does for fees is not only does it compress your files when you are sending it to PACS or to your VNA, but you don't have to send the whole 10-15 minute study. You have the ability to subclip, very much like your MBS, where you just have those 5-second subclips that are labeled. You have the same ability with the TIMS software for fees. So you can just send over those video clips and those snapshots that are relative to your diagnosis that you want to make sure you archive. So don't let the talk about archiving and the file size be a factor that PACS says no to archiving. There is a workaround. And we are quickly going to show you a video demonstration of the TIMS software.
So I can kind of narrate what we're doing. So as you can see, I am just moving our cursor along the timeline. You're able to perform that frame by frame review with synchronized video and audio that we mentioned is critical in fees analysis. Now we're going to open our notes tab here. So you can see that I took some notes. So in my own practice, I like to take that sticky note around. I remember back in the day before TIMS MVP, I actually had a physical sticky note that I would write notes on and then have to go retype it in the EMR, which was a lot more work. So again, just scrubbing through here on the timeline. And as Ashley mentioned, I'm going to make a subclip here. And I mean, everyone has their, own preference for how they perform fees. I like to just record the entire study and then go through and create subclips and snapshots, as Ashley mentioned. So you can see that there in the left-hand bar. But you could also, if you wanted to, record just each individual trial and start and stop recording, just like we do for MBS, if you prefer to do it that way. All right, so now here's my subclip. And here's an example of the scorecards. So you can see that I scored the digest fees and the revised Patterson, but there's the whole list of scorecards that are in TIMS for both MBS and fees. See my revised Patterson there. And TIMS does have semi-automated reporting, which you're going to see here in a second. But if you already have a template in Epic or something, you can actually just copy those scorecards with the little copy button there, which is nice. And then, as I mentioned, there is the compare feature, which I really like using in my own practice. So here I'm just comparing the within the same study. I apologize for the audio there. And then when we pop open our reporting button here and we scroll through, you can see that this is a template-based report in the TIMS software. Those scorecards were automatically pulled forward, as were my screenshots. And then my notes that I took on the little sticky note also were populated. So you can use that report. And like I said, it really increases efficiency in analysis. So with that, I'll hand it back over to Ashley. Ashley, do you have anything to add about the TIMS software?
That it's the best. Okay, so how can I advocate for my fees in my clinical practice? Great question. Let's dive in. All right, so here's kind of your overview for the development of your fees program that I had kind of spoken about at the beginning, and here we're going to dive into a little bit more. So understanding your environment for your fees is crucial to how you start this program. You have to understand your caseload, understand what can this expand to, outpatient, NICU, peds. So you want to understand your environment, what setup would be the best for you, your education, your competency trainings. Again, understanding what is a requirement for your state or your hospital system, speaking to risk management about that, speaking to sister hospitals. How many scopes are you going to need? Are you in a 25 bed facility? Or are you in a 400 bed facility? How many SLPs are planning to be trained? So all of that are questions on how many scopes, and of course your software, how many computers would benefit from having the software. Setting the policies for disinfection with whether that's with SPD, or you have a rehab tech doing the high level disinfectant. Advocates to help support your development program. I think this is really crucial for fees, for SLPs that are starting fees program. Reach out to your radiologists. Ask them, how much of your time are you spent with doing MBSs? I am sure that they will be glad that now there will be another method to assessing swallow because it frees up the radiologist time. So speak to radiologists, get them on your side, speak to the critical care team, respiratory therapists. They no longer have to go down to radiology with you for a trach patient, critical care nurses, GI, ENT, get all of these physicians on your side, these different departments, get them on your side so that when you go to advocate this with the executives, you can say that you've spoken to all these different departments and that they are all on board with it. And then budget, speak to that. Typically, it's the rehab manager that has the concept of how much budget there is. You want to understand the fiscal year, so when that starts, so that you do have the ability to know when to put this into budget. Equipment needs and preferences, as Brooke has mentioned, the single scope or the reusable scopes, which one is beneficial for you, how many scopes. So if there's going to be, 5, 6 of you SLPs scoping, you're going to need more than one scope. How many fees are you planning on doing a day? You can kind of base it off of your MBSs. Scope preferences, very much preference on the SLP, if you like a heavier scope or a lighter scope. And then most importantly, how will you record, analyze, and archive your fees? Make sure you get that into your initial proposal. Meeting with those key decision makers, I think that this is crucial. So when you are meeting with those decision makers, the CFO, the CEO, risk management, you are wanting to talk about, of course, why you want to start this fees program. And as SLPs, we start a fees program because it is for better patient care. That's the truth of it, right? We don't necessarily get paid more for being fees, having fees at a hospital. We do it because we know that the patients will benefit from this. However, when we are talking to the executives about wanting to start a fees program, we have to go past I think this is great for the patient. We have to talk about finances. We have to talk about return of investment. And so in that discussion of return of investment, you are not only talking about all of this new population of patients that you'll be able to service, whether it's bariatric, or patients that are too critical to be off the floor, or respiratory is kind of iffy that they don't want to take them off the floor. So you have all these new patients that you can now service. The costs that incur with dysphagia when you're completing it in the radiology suite versus doing it fees. Also your time. How much time are you spending in radiology waiting for a radiologist? So all of that can be in this discussion of return of investment. You're talking about billing codes and that reimbursement rate. You're talking about caseload growth. So as I've mentioned, can this possibly expand to an outpatient service? Benefits to healthcare organization. And what I mean by that is you want this to help your hospital stand out. So if you have an inpatient rehab at your hospital, now this is something that can service the inpatient population as well. If you have a stroke certified hospital that's down the street from your hospital and they don't have fees, but you do have fees, that can be a great factor for your hospital to kind of show off and be different than the other facilities in the area. And so you want to provide all of these numbers up front. If you're whatever, a lot of times these scope companies, if you buy more than one scope, they give you a discount. Same thing with our software. If you buy it for multiple years, it gives you a discount. So these are all numbers that you want to provide for them in their proposal. And most importantly, which I never did when I first started a fees program, and I think this is a great idea, is after the program is established, follow up with them, follow up with your advocates, follow up with those decision makers 6 months or a year down the road. Show them how much you've done, show them how many patients that you've been able to scope and help. Because what this will do is it will help you expand your program, whether that means that you can go to extra courses, get extra scopes, sign more people off, or have them attend a fees course. So you can now kind of show them all of this data that you've done, and how successful your fees program is, because SLPs are great at doing everything. All right, so for resources, and this is a question that we get from so many of our SLPs, and we hear this so often from SLPs as well. If I want to start a fees program, they tell me I have to do it on my own time after work. And we know that takes a lot of your time that you do not have. So here we want to provide you with resources that we have. So on the left-hand side, we have a fees advocacy document that talks about a lot that we've spoken about today: return of investment, billing, the population, benefits, fees versus MBS. On the right side, we have a link to our website that talks about different competency and training programs that are available in the country. And with that, we thank you for watching our discussion, and we're going to open this up to some questions that we have received.
I'm going to stop sharing for a second because I realized that I was sharing and I couldn't put in the survey link. So hold on, everyone, I will get it because I'm sure that that was a question and I wasn't able to put it in the chat. So one second, let me do that. Let's see here. Okay. All right. So, okay. So survey link for ASHA CEUs. Okay. So I just put that in the chat. And then, like I said at the beginning, if you logged on a little bit late, if you can't access that, don't worry. It'll be sent out via Zoom at the end of this webinar. And then you can also send us an email, which I'll put in the chat as well, at tims-univ@tims.com if you need us to email you the link. And then if you want a certificate for ASHA CEUs, feel free to send us an email at that email address. And you'll have 7 days to submit the survey. And then at that point, we will send it over to ASHA, but just know that it can take, 30 to 90 days for ASHA to approve CEUs. All right, Ashley, I know you were kind of browsing the chat. Was there anything that you saw consistently?
Nothing too consistently. So we can talk about integration to EMR. I think that that's a very important topic to talk about. So yes, our software does integrate with your EMR. You do have the capability of putting that report into your EMR. If you have Epic, we are Epic developers, so that software, that report will seamlessly go into your EMR, all of the charts, your pictures and everything. If you have Cerner or Meditech, we can still have a workaround around that specific EMR, and we can work with you to customize your reports so that it does integrate with your EMR. Elizabeth, as far as the TIMS MVP with the indicators, to my knowledge, and Brooke, correct me if I'm wrong, all of our fees software from the beginning has always had the swallow detection software. I don't know that there was ever a fees software version that did not have that. If you have the fees software and you are not seeing that on your green bar at the bottom, make sure that your swallow detection is turned on, and you would do that by clicking on series detect swallows. And so that's where you would turn on the swallow detect.
Yeah, and along those lines, I know I mentioned this, but if your patient doesn't have a whiteout, and so there's no swallow, like you have swallow detect on, but it's not popping up on the timeline, you can add in an interesting event so that you're able to delineate that on the timeline. So if you have questions about that, feel free to send us an email and we can set you up with free training through TIMS. I saw a couple of specific fees performance questions. Denise said, and this was just to the host, but she said, a fees preceptor once told me not to use lubrication because it doesn't help with scope passage and often clouds the images and suggests only considering lube for patients on high flow. What are your thoughts? So we did briefly talk about this, and Ashley mentioned that lubrication definitely can fog up, like you can get on the end of the scope and obstruct your view for sure. I was just at a fees training a few months ago, and a participant put quite a bit of lubrication on there and then pass the scope and then had to pull out because there was just no way to get it off, which I've definitely seen in my own practice and I know Ashley has as well. So it's really, clinician preference. I think if you are going to use it, what I recommend is angulating the scope so it's like this and putting it just on the angulated side to help with scope passage. But again, as Ashley mentioned, you want to be really careful that you don't put too much on there and it gets on the end of the scope and then you have to do a variety of techniques like having the patient swallow or potentially flicking the posterior pharyngeal wall, things that we probably don't want to have the patient doing to try to clear off that scope. So again, clinician preference. I know Ashley and I both use water pretty frequently, literally just dipping the scope into water or just not using anything, and I haven't not had any complaints thus far. I don't know if you have anything else to add to that, Ashley.
No, I do not. I'm going to answer Emily's question about TIM system having the secretion scales. The TIM system, it depends on what version you have. But if you have the TIMS for fees specifically, then yes, it should have that in the scorecard. About twice a year, we do a software update where we're adding more scorecards. So if you do not see it, Emily, please reach out to us to see what version you're running on.
And along those lines, if you were just seeing a demo video for my Tim's, which Ashley and I have like the beta behind the scenes Tim. So there were some scorecards that were on there that you may not actually have in your Tim's, even if you're on the most recent version. I will say that we updated our website to include a page that has all of the scorecards that we've ever created for download. So you can actually just go on that page and download the scorecards and import them into your Tim's. And if you need help doing that, again, just send us an email at tims-unum@tims.com and we can set you up with someone from our team to show you how to do that. But I can let you know ahead of time that you will see the revised Patterson in future software releases as well as the Murray. So super excited to offer more, fees analysis tools.
I'm going to answer Christine's question. Christine, you were mentioning that you have an AMBU system. That you do not know if they have a software package included or in their tablet that will meet the requirements for best practices. I'm not sure. So I know that AMBU does, of course, have the ability to record your study. I'm not sure in terms of its features or how AMBU, Brooke, you might know more about AMBU. We have the ability to connect with AMBU and send it to PACS. I'm not sure if AMBU on its own has the ability to send to PACS, does it?
I do not believe so. I know that many GI teams who frequently use AMBU have been adding TIMS into their practices for this exact reason. So that one of the carts that we showed, it had like the two monitors, and that was a setup with an AMBU system. So I'm being completely transparent. I'm not familiar with their software, so I don't really know what their software looks like. But my understanding is that many teams throughout the US are adding TIMS to their AMBU systems, not only in speech, but also in GI specifically for that reason. So if you need help with that, please reach out to us and we're happy to help with you or help you with that.
Jennifer, you can access these slides on our TIMS website. There is a tab that says TIMS University, and then you will see all of our previous presentation where you will also be able to access this presentation on our TIMS website.
Sorry, one more comment about AMBU. Rachel commented and said that she just spoke with them today and she is interested in integrating TIMS with AMBU. So yeah, Rachel, I will make sure that we reach out to you and can walk you through that process. But yeah, we work very closely with AMBU. They are an awesome team and it's not super complicated to get that set up.
Yes, not complicated at all. AMBU is a really common scope that we or program scope and tablet that we connect to very often to send to PACS. Elizabeth, you brought up a great question. Her question was, I have been doing fees for 2 to 3 years. Is there any guidance on when experienced fees clinicians should be starting to sign off other SLPs for competencies? I think this is a great conversation, a great topic, and I think this is a very personal question in the sense that I think is very much on how you feel as an SLP. It took me many, many years to feel quote unquote comfortable signing another SLP off. And I know that many of the hospitals kind of put this pressure on SLPs to get more and more SLPs signed off, right? Oh, you've been doing it for a few months. I'm sure you're good at it. Go ahead and sign this next SLP off. And so I personally never felt comfortable doing that until I was much more in depth into my practice, and even completing those advanced courses for fees. They do offer advanced courses past the basic training courses. I think those are very vital to being quote unquote able to sign off another SLP, continuing your education, seeing what best practices is. I think all of that is encompassing on what is considered an experienced fees clinician, but there really is no general thumb as to when you can sign off a next SLP.
Yes, yeah, I completely agree with everything you said, Ashley. Let's see.
Average how
Okay.
much time it takes to complete your exam, write your report, make subclips, archive appropriately. Do you have time allocated in your workday for subclipping, adding illustrations, etc.? Honestly, this is minutes long. It is so quick to make a subclip. It takes a handful of seconds to make a subclips. It takes a handful of seconds to make those telestrations. And when you customize your TIMS software where you have your label set already done, you have your notes already customized, you have your report customized, you can be completing all of that, subclipping, labeling very quickly. Our TIMS software is very easy to use, especially if you're used to the MBS one. So I don't necessarily have a separate time allocated in my productivity to do all of that, because the TIMS software is all encompassing in the sense that you are doing all of that while writing your report at the same time. So this software does save you time versus doing this separately. So I don't necessarily, I believe Brooke is in the same department. We don't have a separate time allocated to subclipping and illustrations and annotations because it is done so quickly on our software.
Yes, sorry, I'm seeing some more just logistical questions. If you need the survey link, it is in the chat. And then if you missed any of this webinar, the recording will be uploaded on our website either tomorrow or the next day, pending Zoom logistics. But the slides are already available on the website on the fees program development and advocacy page. So with that, I know we didn't get to everybody's question, but if you have a question that we did not get to, feel free to email us at that email address I mentioned, tims-univ@tims.com. We do have hours and hours of free continuing education on our on-demand page, but we do also offer free training for TIMS on a weekly basis with speech language pathologists on our team. So feel free to reach out to us. You can also always send us a DM on Instagram. We're happy to chat there as well. And with that, we will close out for the evening, but we appreciate you all for joining us tonight.